I sincerely thank my friend Ayman Fakri and all the friends from the Egyptian Venous Forum. So my topic today is to speak about how to improve our outcomes in sclerotherapy. So during my presentation, I will try to give some tips and tricks, but also to provide some scientific data to advance our clinical practice, let's say. This is my disclosure slide. Okay, whenever we treat varicose veins, we know that we need a good diagnosis. And this is the very first important, let's say, trick to avoid complications and to get proper treatment. That's why long time ago we provided a few documents such as this one and this one concerning the best way to approach our patients with varicose veins through duplex investigation. Why? Just for example, we sorry we need to know exactly how is the situation of the saphenofemoral junction in case of varices related to the incompetence of the great saphenous vein or the saphenopopliteal junction for the small saphenous vein. So why? Because there are many patients who exhibit reflux in the great saphenous vein, but in fact there is no reflux at the terminal valve, which means that probably the patient has a lower hydrodynamic column, and that's why our sclerotherapy could be somehow more effective. So the hemodynamic and morphologic condition of the terminal valve, which you can see here, and of the pre-terminal valve, which you can see here, is something we should know before approaching the patient. Furthermore, we know that only a very little part of our patients exhibit a complete reflux from the groin to the ankle in the great saphenous vein. Again, we should target the proper vein for the proper treatment. And so the majority of the patient, for example, may exhibit a reflux down to the knee, and that's why this is the segment to be ablated by sclerotherapy, for example. One more issue is the anterior accessory saphenous vein, which is a kind of ghost in literature because there is very, very little report about the anterior accessory saphenous vein, which on the contrary is responsible for varicose veins in about 10 to 15% of our patients. So the anterior accessory saphenous vein is in another location, a little bit more lateral to the great saphenous vein. And again, this is a proper diagnosis to be planned. The small saphenous vein is even more complicated. We know about that. That's why proper duplex investigation will help to improve the treatment. What about the perforators? The perforators, that would be a very long story to discuss. What we know is that in primary varicose veins, the majority of these lower leg perforators are re-entry perforators. So probably we could avoid to treat these perforators at first instance, and then we should wait after ablating the saphenous vein, the tributaries. We should wait and see what happens, and the majority of these perforators would return competent. Concerning recurrent varicose veins, we should investigate very carefully where the reflux comes from, because everybody knows that we have patients, for example, with refluxes all around the leg, but the real let's say source of the refluxes is in the pelvic area or in the lymph node vein network around the inguinal area. So to make it short, these are perfect cases for sclerotherapy, for example. On the contrary, there may be patients who exhibit recurrent varicose veins related to the anterior accessory saphenous vein or to anyway a reflux in a persistent saphenofemoral junction because of a malpractice of a different strategy or progression of the disease. So at the end of the day, what we need is a proper mapping. Once you have a good diagnosis, then you have a good treatment. This is the very first message to take home, a proper mapping prior to our sclerotherapy. When we deal with minor varicosities, reticular varices and telangiectasias, things become more complicated because we really don't know hemodynamics of these minor varicosities. That's the issue. So we treat the varices the minor varicosities without knowing the pathophysiology. Why? You see here, for example, the classical Albanese system with the telangiectasias here and some reticular varices above and below. So a classical upside down tree is very easy to understand that we should anyway treat this vein before the telangiectasias because the reflux comes down, as you can see in this classical example. But there are patients where the reflux does not come down, but probably goes up. Or anyway, we have a lot of telangiectasias draining into a reticular varicose vein. So what to do? That's the issue. Probably we could start from the telangiectasia and wait and see what happens to the reticular varices draining in a perforator here, or with an incompetent perforator. Even more complicated when we have this situation, for example, with telangiectasia above and below a reticular vein, reticular varices. So this is an issue for our sclerotherapy. That's why probably to work, let's say, in a smooth manner could help. And then, of course, we have telangiectasias and reticular varices related to a kind of hidden great saphenous vein incompetence or small saphenous vein incompetence. This patient came to me and told me, "Doctor, please inject my telangiectasia. I want my leg clean." I investigated the patient and I found an 8 millimeter small saphenous vein refluxing. So I told her, "I cannot treat your telangiectasias. I'm sorry. I need to treat your saphenous vein." She was disappointed. She went away, came back to me with a lot of pigmentation because she got sclerotherapy of telangiectasia without treating the saphenous vein. And that's a major mistake, let's say. So how should we treat our patient with sclerotherapy? Raymond Tounet was one of the fathers of sclerotherapy. Let's say from above downwards and from larger to smaller veins. These are two basic rules with some alternatives. So when we speak about minor varicosities, reticular varices and telangiectasias, we mostly use and should use liquid drug. So we should start from larger to smaller, from upper to lower refluxes. Whenever we inject the reticular varices, we should aspirate blood before injecting. That means we are into the vein. This is not possible with telangiectasia. Then we should always use air block because injecting some air into the vein prior to liquid entrance, that means that we clear the vein. We improve the outcome because the lower the blood, the better the outcome. And then again, minor concentration, minor doses, which means, for example, 0.1, 0.2 milliliter for telangiectasia and 0.5 or 1 milliliter for reticular varices. So overall, I would say multiple injections and low doses at low concentration. This is a kind of basic rule when we deal with minor varicosities. We have different drugs, which we can use at least in Europe, and we will see very briefly. For example, polidocanol, we could start from 0.25 even to 1% in liquid form. This is a medium sclerosant power. It is transparent fluid, very easy to manage, and the extravasation risk creating necrosis is not so high. Let's say that the pigmentation could be a little bit an issue. Then we have sodium tetradecyl sulfate, which is not probably the most used one for minor varicosities. We are talking about minor varicosities now. 0.1, 0.2%. It is stronger than polidocanol. That's why you should take care of your necrosis risk, for example, and you may get some allergies. It's not so powerful when you extravasate, so you should combine it, for example, with the sodium salicylate to get some pain when you extravasate. Another possible drug is chromated glycerin, which mostly is used diluted with water or with mepivacaine because it is quite viscous and it is very safe because it's very weak. So you should use it, let's say, for little telangiectasias and so on, but it is painful when it is extravasated. And then sodium salicylate, which is so old and so good, let's say. It is probably the oldest of all the sclerosant drugs for the minor varicosities. Anyway, it has a low sclerosant power. It is transparent, very easy to manage. Of course, you can get allergy only if the patient is allergic to acetyl salicylic acid. And the pigmentation rate is the lowest among all these sclerosant drugs. Material. What should we use to inject our patient? Of course, needles. For minor varicosities, I would recommend 30 gauge needles or 27 gauge needles. And then the classical material that you can read. Let's say syringes. I wouldn't use 1 milliliter syringe because you inject with too much pressure through the piston and then you get more easily extravasation or whatever. So 2.5 or 5 milliliter syringe would be better. I'm used to apply some creams after the injection, some venotropic anti-inflammatory creams on the treated areas, and my patient usually get some food supplements or drugs in selective cases such as heparin or whatever. Then now we come to foam. Foam has been discovered, let's say, around 80 years ago, but was somehow resuscitated, let's say, by Lorenzo Tessari, before Lorenzo Tessari, by Cabrera, Monfreux, and others. But anyway, the real diffusion of foam is due to Lorenzo Tessari's invention of the three-way valve technique. Unfortunately, it is not so good for minor varicosities. These are two slides where we clearly see that we can get some necrosis with foam if it is too high the concentration. So for minor varicosities, still I would advise to use liquid drugs. Okay, we may have some cases such as this one or this one, a kind of matting, where foam sclerotherapy may have a role, but generally speaking, I would prefer for telangiectasias and reticular varices liquid sclerotherapy. So you can use foam, as you can see here, for example, through proper needle. In case you use foam, probably 27 gauge needle is better than 30 gauge because otherwise you disrupt the bubble and the foam converts into liquid. So which are the volumes per injection? So per injection when we use liquid sclerotherapy. This is a kind of consensus which was published in 2013. As you see, for telangiectasia, up to 0.2, for reticular veins, up to 0.5, and for varicose veins, direct injection, for example, up to 2 milliliter, liquid sclerotherapy. When we, on the contrary, speak about concentrations, here it is really difficult. Let's say that some tips and tricks, okay? Whenever you inject telangiectasia, you should use low concentration because 0.25 polydocanol or 0.1% STS could be enough. If it's not enough, you can increase. For varicose veins, you can use a double concentration, for example, 0.5 polydocanol or 0.2, 0.3, 0.5% STS. When we talk about varicose tributaries, then we start to use 1% polydocanol, 0.5 or 1% STS. When we talk about larger veins, for example, saphenous veins, small saphenous vein, great saphenous vein, anterior accessory saphenous vein, or venous malformation or recurrence at the groin or at the popliteal area, then I would recommend to use in the majority of the cases 3% because this is the escape point, this is the major source of reflux, let's say. So you should never, let's say, use the standing position to inject the patient. I would largely prefer the supine position, and you should control the perfect position of the needle and try to understand immediately if you are extravasating because you should get some pain, you should see some bubble. if you inject air, I mean, if you use air block, then you would extravasate air, which is a safety measure. Uh, you should, well, this is a great debate, but you could or should, I don't know, use compression. There is some debate, as we will see, but overall, compression by stockings especially is helpful to decrease side effects. You can use eccentric compression through rolls, through latex, through pads, and the duration of compression may depend on the kind of veins that we treat. For example, a lower duration for telangiectasians and higher duration for varicose tributaries and saphenous veins. And normal walking is encouraged in these patients after the treatment. Of course, on the contrary, sauna or exposure to sunlight is not suggested immediately after sclerotherapy for the risk of pigmentation. One thing we may do before puncturing the vein is to elevate the limb. That would result in a reduction of the diameter of the vein which we have to treat. Of course, the smaller the vein, the higher the difficulty to catch the vein. We know that. But the smaller the vein, the lower the blood amount, which is very interesting. That's why somehow we also use compression in sclerotherapy. For example, what we do with compression is to try to optimize the result because we reduce blood in the treated vein after the treatment. We can so improve fibrosis. We know that sclerotherapy results in sclerothrombus. This is the final result. If you have more blood, you have more thrombus. If you have less blood, you have more sclero. You have more fibrosis. That's why the reduction of blood into the vein before and after sclerotherapy is a major key point in sclerotherapy. Anyway, what we know from literature, let's say for sure, is that you reduce side effects through compression, pigmentation, inflammation, hematoma, clot retention, and so on and so on. So compression overall is probably the best way to, together with the proper technique and strategy, the best way to reduce side effects in sclerotherapy. For example, eccentric compression. This is an elegant demonstration from Ugo Parch that through eccentric compression like this, or let's say normal latex pads and so on, you can achieve the occlusion even of the saphenous vein, which is so difficult, especially at the thigh region. And that's, for an example from Ugo Parch, how stockings plus pad can significantly reduce the diameter of the great saphenous vein. So the importance of the eccentric compression and of pads during sclerotherapy. Unfortunately, compressing telangiectasias is impossible. Impossible to compress telangiectasia. Even 100 millimeter of mercury, always our giant and master Ugo Parch showed through these elegant pictures, you cannot compress telangiectasia because they are dermal varices and you cannot compress the dermis. So the only way to compress is through let's say plasters in a tangential way. This is the only way to make your telangiectasia disappear, to reduce the blood inside the telangiectasia, not perpendicular, but tangential. Let's say that the combination of compression and immobilization is important in foam sclerotherapy because compression should be somehow delayed a little bit when you use foam. And anyway, the patient should be immobile for a few minutes after foam sclerotherapy. That would reduce the dislocation of foam significantly. If you immediately compress or if the patient immediately moves, your foam will move and the result will be lower. So let's go to foam sclerotherapy. This is the second part of my presentation. Let's say that the smaller the bubbles, the better the foam, the better the outcome. So one main goal is to achieve a small bubble foam. This is very important. Which are the variables which condition our formation of foam? Of course, the drug. For example, STS gives you smaller bubbles than polydocanol, but gives you shorter life foam than polydocanol. Then air or gas. I prefer gas, CO2 plus O2. You can use air. Air gives you longer lasting foam, but larger bubbles. And then the ratio 1 to 4, 1 to 3, 1 to 5. There is some consensus that 1 to 4 is an average proper ratio. So 1 part of liquid, 4 parts of air, or 4 parts of gas. The material, low silicon syringes or no silicon syringes. For example, you can see here low silicon syringes and no silicon syringes, which means you reduce foam coalescence if you use low silicon or no silicon syringes. I can tell you very simply, I've been giving courses about foam sclerotherapy in several countries, including Egypt, where I was a few times in the past, let's say. And I was in Holland, in Spain, in France, in Serbia, whatever. And they always give me syringes to produce foam. That's why I bring my syringes wherever I go, because you can use 100 different brands of syringes, but then you get very bad foam, because there are several syringes which are full of silicone and you get very liquid foam. So it's a nonsense, and it becomes liquid in 20 seconds. It's a nonsense. That's why the material is very important. These are the needles, these are the drugs, the three-way valve, and so on. Then you should inject your foam through proper needles. For example, 25, 23 needle are good needles generally. You can also use 21, but okay, let's say that 25 and 23 gauge needles are okay. Otherwise, you can use, let's say, cannula or catheter, as I will show in a second. And then when to inject, how to inject, where to inject, which are the complementary measures. Again, I told you about compression and immobilization. The best way to inject deeper veins, which means, for example, saphenous veins, perforators, tributaries, and so on, is through the ultrasound guidance. So the ultrasound guided foam sclerotherapy is very interesting to target proper veins. Otherwise, you can inject under visual control all the tributaries. What we know from literature for sure is that foam sclerotherapy is less powerful than laser radiofrequency in terms of occlusion rate. This is true as to this study, and this great study at 5 years demonstrated that laser is better than foam and surgery in terms of quality of life, and so on and so on. So when we deal with larger veins with a lot of blood, foam suffers. Suffers because diameter is the main variable. Blood is the main enemy we have when we perform foam sclerotherapy. Have been working for many years in Ecuador and Nicaragua in solidarity missions, and we have all patients like this, full of varices everywhere, 15 millimeter saphenous vein. So foam is an option, but we know that recanalization will come when you have such large veins. That's why in 2009, I and Lorenzo Tessari started to promote a few improvements to get better outcomes with foam. Catheter, tumescence, irrigation. These are the three major elements to improve the results of foam sclerotherapy. Kurosh Parsi also published together with us, in the same issue, this elegant drawing and demonstration how you can put a catheter and then through tumescence you dramatically reduce the diameter of the vein prior to foam injection. Why should you reduce the caliber of the vein prior to foam injection? Because the higher the diameter, the higher the recanalization rate. The higher the blood flow, the higher the recanalization rate. So, which is our enemy? Our enemy is blood. We hate blood into the veins prior to sclerotherapy. And was also clearly demonstrated in several studies because blood contains proteins. Blood contains red blood cells which stick and neutralize the sclerosant drug into the bubbles. Okay, that's the issue. We also demonstrated in this study how protein binding on sclerosant drugs can deteriorate foam and can reduce foam efficacy. That's why tumescence. Tumescence is being used for laser and radiofrequency normally. It decreases vein size, and this means that at the end of the day, you decrease blood content into the vein prior to the injection. This is an elegant demonstration that I got a long time ago. This is a great saphenous vein aneurysm. It was 24 millimeter in supine position, 38 millimeter in standing position. So this was a vein like this, okay? Godzilla. I put tumescence and I got a cat. From Godzilla to a cat. Everybody would agree that treating this vein is much easier than treating this vein. That's the meaning of tumescence. Never treat this vein or 10 millimeter vein because the recanalization rate could be high. When you treat 1 millimeter vein, the recanalization rate is much, much, much lower. This is what we demonstrated, for example, in this study. We treated patients with catheter and tumescence, and we got better occlusion rate using tumescence under duplex guidance. You see around 82% occlusion rate or some good antegrade flow in the treated veins after 14 months. So it was a kind of medium-term follow-up. And the residual great saphenous vein diameter is quite small, 0.9 millimeter. Another issue which we can keep in mind is irrigation. I mean, with tumescence, you reduce the caliber prior to foam injection if you put a catheter or a cannula inside. With irrigation, for example, saline solution into the vein prior to foam entrance, you dislocate the blood and you empty the vein. And that's the perfect moment to put your sclerosant drug because that means that you will get a desert prior to the sclerosant foam entry. So you can use different systems to irrigate and flush the vein, but if you put the catheter, you perform tumescence and you irrigate the vein prior to foam, then this is the catheter, then the foam enters and you can see a 1 millimeter vein filled with foam for at least 20 minutes. And that's one of the major secrets to get a perfect or let's say a very good result even at 5 years because you get fibrosis, you don't get thrombosis because there is nearly no blood. That's the simple secret. So we performed the study after some years of experience. We performed a study treating the great saphenous vein with the catheter foam sclerotherapy plus tumescence and irrigation, and the tributaries were removed by means of phlebectomy. This was published in 2017 in the European Journal of Vascular and Endovascular Surgery. We treated the 88 limbs, but we were masochistic. Why? Because we wanted very large veins. So we did not treat normal veins. We treated very large veins, the worst ones, to get good outcomes. When you stress a technique, you should make a kind of stress test. This is a kind of stress test. 8 millimeter average diameter. This is a very large diameter if you look at the literature. So the final, these are the material. Everything is done in local anesthesia, cannulation with the classical transcutaneous cannulation, an intrasaphenous 4 French catheter, which has a closed tip and side holes. And then you perform tumescence, then you perform irrigation, and then in the tumescence you put adrenaline, so to have also a chemical spasm of the vein, not just a mechanical one, but also a chemical one. And then we use in this specific group of patients 3% STS, and the gas was CO2 70%, O2 30%. Tessari method for French long catheter. This is the kit, the compression in this case with the Struva 35 after the procedure. These were the results. At 36 months, so 3 years after the procedure, without any additional treatment, so one single treatment, one single shot, we got 5% recurrence rate from the clinical point of view. But more importantly, we got around 96.5% reflux-free great saphenous veins at 3 years. It means we got 89.4% occlusion rate, but there were 7.1% of saphenous veins which were patent, but with antegrade flow because of the low diameter and of the absence of sufficient compliance to get a reflux. These results are completely similar, overlapping laser, radio frequency, and so on. And these are, for example, of duplex results with the disappearance of the vein because of fibrosis and not thrombosis. So I was so happy about my technique. I gave courses about foam sclerotherapy. A few Egyptians came to my courses and they published it before me in the European Journal of Vascular and Endovascular Surgery. This is an Egyptian publication in the European Journal just 1 month before my publication. I was very happy about that. And they got basically similar results. You can see here, quite similar results with catheter foam sclerotherapy and tumescence. Which are the complications of this technique? Basically, there are no relevant complications beyond the possibility of a DVT or a superficial thrombophlebitis. So if we look at this systematic review and meta-analysis, they clearly showed that the, let's say, catheter foam sclerotherapy is much better than the ultrasound guided foam sclerotherapy. So when treating especially large veins, we should use this kind of technique. Also because it is much, much, much less expensive than the other techniques. So about this technique, we can say that we could now have a technique which is good for several types of veins, also larger veins, but we should use tumescence and irrigation prior to including foam. So going to the end of my presentation, just a few slides, contraindications to reduce, let's say, side effects, allergy, acute DVT, immobility, and so on, but also symptomatic patent foramen ovale. If we know that a patient has a symptomatic patent foramen ovale, there is no issue for sclerotherapy. There is no possibility to perform foam sclerotherapy because we know we may have a cerebral embolization. With relative contraindications, it's a mess, let's say. It's a chaos because somehow the experts say an individual benefit risk assessment is mandatory. It means it's not possible to say yes or no, but you can see here, for example, concerning the thrombophilia, you should evaluate the patient before taking a decision. Okay, now we talk very briefly about the complications we may get with the sclerotherapy. Overall, they are not so common. This is from the publications I showed you before. They are not so common, and the most common, of course, are pigmentation and the clot retention and phlebitis. Okay, let's go step by step. Urticaria, allergic reaction, skin reaction. This is possible because of an allergy, but it is a kind of self-limiting and lasts usually up to 30 minutes. Blisters, it could be due, for example, to what we use as materials on the skin. So pay attention to possible materials which can create some reactions. Clot retention, this is an issue because it could be common when treating especially varicose tributaries. That's why they cause pigmentation, and you should remove the clots, for example, through an 80 gauge needle after the treatment, because otherwise they may result in pigmentation. These are just examples of trapped blood removed by means of 18 gauge needle from the treated varicose tributaries. Pigmentation, again, I told you, is the most common, around 10, 20, 30% according to the literature. But at 1-2 years, the vast majority of these pigmentations have gone away. So somehow foam could be a little bit worse in terms of pigmentation, but again, it depends on technique. You see here some pigmentation, and then matting. Matting could be a result of improper technique, could be a result of, for example, of drugs. A few patients get drugs which can induce some matting. I would say that they tend to resolve, but not all of them, and that's why you should retreat the patients in a different way with different concentration. Anyway, you should wait for a while before retreating the patients. This is one of my mattings. Let's say this was terrible because I just treated a couple of reticular varices and the patient came back full of telangiectasia. I was, let's say, shocked. There was some hidden stuff around. Superficial vein thrombosis is another possibility, we know, with the sclerotherapy, but this is again probably due to too much blood in the treated veins, maybe not adequate compression, too high concentration, and so on and so on. It may happen also weeks after the treatment, 2-3 weeks after the treatment. We know that we should treat it with compression, anti-inflammatory drugs, and often with low molecular weight heparin. Tissue necrosis is more important, but luckily it is much rarer. Could be an injection outside the vein, could be, I mean, in the extravasation, could be, unfortunately, an injection of the arteries, but sometimes it's a kind of embolia cutis medicamentosa. You inject a vein here, you get necrosis here, 50 centimeters distant from the place where you inject it. It means you forced the arteriovenous sphincter and the liquid or the foam goes into the artery and then down to another area. These are examples from a friend of mine of ulceration after sclerotherapy. Deep vein thrombosis, pulmonary embolism, it is an issue. We know it could happen up to 2% in foam sclerotherapy. Pulmonary embolism is much rarer. It could be due to thrombophilia, could be due to a wrong technique, and so again use compression to reduce the incidence and encourage the patient to walk. But the dose of foam is also important. When you use more than 10 milliliter, more than 12 milliliter, even more than 15 milliliter, the rate of DVT is higher. So the dose is also important to reduce the deep venous thrombosis rate after sclerotherapy. Pulmonary embolism, we have very little data. You see here one case out of 1,025 patients in this French series. I do think it's really a matter of thrombophilia in these patients. And then let's go to the neurological issues, visual disturbances, migraine. We know that they can be part of PFO existence, unknown. There can be a right to left passage, let's say. That's why using probably CO2 or CO2 plus O2 could be an option. There are cases of TIA, transient ischemic attack and stroke, but they are, again, really rare. They can come with liquid and come with foam. When it is immediate or early, it's a matter of gas. When it is delayed, let's say 7 days later, 5 days later, it's a matter of clots. This is a clear differentiation. So if a patient experiences some visual disturbances, it could be a TIA or it could be a migraine, we know that. Anyway, try to minimize the volume to reduce this possibility. And the patent for amenovale can be an issue. So let's go to the end. Why this slide before concluding? Sorry. Why this slide before concluding? Because the very last tip and trick before treating the patient with sclerotherapy is to treat the patient, not just the leg, not just the veins. Because if you treat this patient who is obese, who doesn't walk, who has a lot of hormone problems, and so on, you can get bad results because of the patient, not because of the doctor. It could be an issue of the doctor, but again, you should encourage the patient to improve her lifestyle, her nutrition, stress management, and so on and so on. Thank you very, very much.